This is Brenda, owner of Zackle & Associates. In the last video, you learned about the physiological effects of prone positioning, best practices, and special considerations. This week, you will gain a better understanding about lateral positioning. Lateral positioning is common during procedures that involve the hip, shoulder, elbow, kidney, and thoracic procedures. Extra pressure is placed on the patient's dependent side or non-operative side. In the positioning section of the intra-op record, check documentation to see which areas were padded, including the ear, acromion process, olecranon, iliac crest, greater trochanter, lateral knee, and malleolus. During prolonged surgery in this position, the patient can experience reperfusion injury, meaning tissue damage caused by the blood supply returning to the tissue after a period of ischemia, or lack of oxygen. This can lead to rhabdomyolysis, a condition that can result in permanent disability due to a breakdown in muscle. If this occurred, check the medical record for documentation reflecting repositioning changes during surgery. Best practices for lateral positioning include: maintain the head and neck in a neutral position. Place the head on a head positioner or pillow. After positioning the patient, check the dependent ear to make sure it is not folded. Protect the eyes from ocular injuries during general anesthesia. For example, the anesthesia professional most commonly tapes the eyes shut to prevent these injuries. Based on the physical limitations of the patient and specific needs of the surgery, the patient's arms should be supported and secured. The upper arm is neutral with the shoulder and the palm is facing down. The lower arm should be on the same plane as the OR mattress and the palm is facing up. Depending on surgeon preference and type of surgery, the upper arm can be secured in a lateral positioner, pillows in between the arms, or the upper arm could be suspended in a positioning device or held by one of the surgical teams if that arm is to be operated on. An axillary roll should be placed under the dependent thorax distal to the axillary fold. This improves cardiac output and avoids compression of the brachial plexus. The upper leg is in a straight position to provide stability, and the dependent leg is flexed at the hip and knees with pillows in between. All bony prominences should be padded with foam or gel pads. Because the skin in older adults may be fragile and susceptible to pressure injuries and have impaired thermal regulation and slow healing, it's important to reposition the patient when possible and to document a skin assessment before and after positioning. Did your client suffer from a deep tissue injury, joint dislocation, or nerve damage due to a surgical positioning error? Let our legal nurses educate you on the severity and long-term effects of your client's injuries. This is Brenda Zackle, bridging the connection between medicine and law.